Thank you, Emmanuel. We hope you had a nice lunch break, some interesting discussions. I'm really grateful for the questions and the short topic sessions on Estimands that already provided a good setting the scene. My name is Vivian Lanius from Bayer, and it's our pleasure, Andreas and mine, to welcome you to this session celebrating the 5th anniversary of the ICH E9R1 guideline. In this session, we will first have the 3 presentations, and we will hold all questions until the panel discussion. And now Andreas will introduce the first speakers. Over to you.
Yeah, welcome also from my side to this session. So it's a great pleasure that we, so to say, have 2 of the fathers of the ICH E9 addendum as speakers of the first presentation. So virtually, we have Frank Bretz, who joined Novartis in 2004, and there he is currently a distinguished quantitative research scientist. And as I said, he was a member of the ICH E9 expert working group on Estimands, and he also currently serves as an expert for the ICH E20 working group on adaptive clinical trials. And our second speaker for the session is here in this room. It's Rob Hemmings. So he works currently as an independent statistical and regulatory consultant. And before that, he was for almost 20 years at MHRA and served for many years in EMA, CHMP, and SORB. And he was the rapporteur for the ICH E9 addendum. So please, floor is yours.
Testing. Frank's online.
Yes, can you hear me?
Excellent. So thank you for the invitation to be here. Thanks for the introductions. I know Frank would much rather be here in person, of course, and not least because he could have done more of the slide presentation. We want to talk about Estimands being implemented but not fully embraced. We have some important acknowledgements at the bottom of the slide from people who've contributed ideas and discussions and contributed examples. Celebrating 5 years, maybe we should be celebrating 10 years. The original concept paper was published 10 years next month, October 2014, and highlighted issues arising from the absence of guidance on the primary estimand for a confirmatory clinical trial. Wow, that's a lot of words. What was the problem we were facing at the time? Well, there were many conversations about handling missing data. And there were some examples of sponsors who had collected data in a study but not used them in an analysis, chosen to ignore data that had been collected when conducting their analysis. How do you assess that? How do you critically appraise those choices? How do you make any judgment as to those, unless you have an idea of what it is you're trying to estimate in the first place? How can you decide which data are relevant and what to do with data that you don't have, unless you have a target of estimation in mind? That was the fundamental concept behind initiating this work on Estimands. Ultimately, what is it that we're trying to learn about our experimental medicines when we conduct clinical trials? So the working group was formed. Frank's here as well, I see, and we worked for 2, 3, 4 years in producing a draft and a final guidance document, which has now been adopted in many regulatory jurisdictions around the world. And it's had some, what we would see as positive impacts. It's much clearer now that we're making choices for our data analysis, in particular which data to use and how to handle missing data, in alignment with a stated clinical question of interest. Please note the word stated. So we are writing something down about what our clinical question of interest is. We make a statement. We promote patient retention on study if we're interested in treatment policy questions. You see this as regulatory feedback and as sponsors writing this into protocols a lot more. We will make every effort to keep the patient on the study and keep collecting the data. And I think it's true to say that sensitivity analysis, which was the sort of second part of that Estimands guideline, is more focused on assumptions and data limitations of the main analysis and less likely to be a sort of scattergun approach of lots of different ways that I could possibly analyze these data. I think the other positive, and I'm reflecting on the conversation this morning and those unrelated deaths early in neuroscience trials, is that we're actually having proper conversations about difficult problems. There's plenty of examples of issues in data sets that always happened. Early deaths unrelated to disease progression have always impacted clinical trials. And we've made slightly opaque choices about what to do in the statistical analysis section of our protocol and our SAPs. Well, now we're having these, what I think to be better conversations about what it is those events tell us about the treatment we're interested in. But we're not there yet. There's still plenty of way to go. I think we're not routinely involving all relevant stakeholders when agreeing the clinical question of interest. Please note the use of the word agreeing here rather than stating on the previous slide. We do state Estimands and clinical question of interest. I don't think we can hand on heart say that they're properly discussed and agreed with all relevant stakeholders. And we're still not always using an agreed clinical question of interest as the starting point to discuss trial design and analysis. Again, hand on heart, I think we all have to say sometimes it works the other way round. I work out which analysis I'm doing or what trial design I think I can do, and I write the Estimand accordingly. Importantly, we assert that we're not getting a good trade-off between the clinical question of interest and the reliability of the analysis. This relates to Frank Patavi's comment this morning that the guideline promotes first a discussion of the clinical question of interest, and second says if you genuinely can't get a reliable estimate of that, you may need to think of another clinical question of interest where you can. And we work towards either a paragraph of text that states the Estimand or a table that lists our Estimand attributes, including intercurrent events and strategies that articulate the question of interest in respect of those intercurrent events. I think one thing we really want to get across in this talk today is that this is not the end. This is not the point of the Estimand conversation. The point of the Estimand conversation is to derive a specification of the clinical question of interest. This is a means to get to that end. Frank, can I pass to you?
Sure, thanks. I have to say that on my screen, the format of the slides looks a bit different. I don't know how it is in the room. So
it is different, Frank. I think
okay.
The highlights have been lost and the animations are lost. We make the best of it.
Okay, because I cannot read the full text. It falls off the screen on in my view. So maybe Rob, you just continue. I feel that's better. Yeah, that's how I see it.
Does it help?
No. Yes, it goes across the page.
Who was it earlier apologizing for the amount of text on the slides? Frank, can you continue, or do you want me to do it?
Just please feel free to continue if you feel comfortable.
Okay. Sorry for that, Frank. I don't know why that's happened. Yeah, this is messy, I'm afraid. Okay, we do our best. So what do we want to do today? We want to use some examples. Some of them are real examples. Some of them are sort of mock case studies that you can recognize, to highlight some points to consider when contemplating whether a strategy truly reflects a clinical question of interest. This is a non-exhaustive list of interesting cases. There were many others that we discussed and dismissed for not having time. Our starting point is that regulatory advice from EMA, from FDA at the moment, sort of defaults to a treatment policy strategy. Maybe that sounds a little bit provocative. Happy to carry that on in the panel discussion. But that's our starting point, that there's some sort of element of default to using treatment policy strategies for discontinuation of treatment, for use of additional treatments, et cetera, and that default is based primarily on statistical considerations rather than on clinical considerations. And the undeniable benefit, if we use all data as randomized, we're adhering to randomization and to the ITT principle. Now, it is a talk of some technical terms to a room, predominantly of statisticians, but we will talk about treatment policy, and hopefully people understand what that means. We will talk about other labels given to strategies, and we will talk a little bit about intercurrent events. In respect of treatment policy, what we're saying, of course, is that the occurrence of the intercurrent event is irrelevant in defining the treatment effect of interest. I am interested in the patient's outcome, regardless or not of whether an intercurrent event occurs. I am interested in their outcome, regardless if they discontinue treatment or regardless if they take another treatment. And we want to promote some discussion amongst the panel, amongst the audience, that if we're right, what's the reason behind this predominance of the treatment policy strategy? And when does it truly reflect a clinical question of interest? We want to talk about how we can promote the involvement of other disciplines into the conversation, and fundamentally get you all thinking about, why is it that we're doing clinical trials? What is it we really want to know about our interventions? And so sorry for all the slide formatting. I don't know why this has happened. The first example is a case where the treatment policy question, at least to us, seems relatively controversial. And what it does is teach us about the effect of a treatment sequence. So the condition here is AML, acute myeloid leukemia, and you can read a little bit about that on the slides. There's a standard of care that's currently in place. And you can see just about at the bottom of, whoa, maybe I won't touch that. You can see just about at the bottom of the slide a treatment pathway that the patient might undergo with steps of induction, remission, whether or not the patient qualifies for transplant, which may take them into transplant or otherwise into consolidation therapy. So it's a fairly complicated treatment pathway. And we have an idea to assess efficacy and safety of a drug called midostaurin added to the standard of care and continued through maintenance therapy. So we're adding an experimental intervention into that treatment pathway, and we'd like to know whether there's an effect on survival times. Now, we give midostaurin relatively early in that pathway, and it's possible that there's different effects of the drug. It may have a direct effect on survival times or the way the disease progresses. It may also have an effect on the eligibility of patients to receive transplant, as well as on the outcome of transplant. So quite complex series of drug effects. But transplant is part of clinical practice, and the treatment effect of main interest seems to be that of midostaurin on the overall treatment strategy, which includes the option of SCT. So if we look at survival times under a treatment pathway that includes midostaurin and survival times on a treatment pathway that excludes midostaurin, we might see a difference in those survival times. Part of that might be mediated because midostaurin is having an effect on the proportion of patients who can have a transplant or the outcome of that transplant, rather than being a sort of direct effective drug on survival times. That's what the treatment policy question answers. But a positive result under that treatment policy question still seems to say that midostaurin is a useful drug. It would be sufficient to tell us that midostaurin is efficacious, even though we don't directly estimate only the effect of midostaurin as a treatment. And we don't isolate the impact on survival of any of those given effects or steps in the treatment pathway. But that seems to be a case where answering a treatment policy question, which tells us the effect of the treatment sequence overall on overall survival, still gives us enough information to approve a specific drug. So this second example then is slightly different. And in fact, we modify it to consider a setting where the experimental treatment is used in both the experimental arm and in the control arm. That sounds weird, right? But this happens particularly in the oncology setting, where we might have an interest in overall survival. And many drugs have a plausible mechanism of action and promising data from an early phase of development, such that when you initiate a randomized controlled trial of new drug versus best supportive care, there's an argument for a clinical or ethical imperative for crossover. So the choice of treatment in the control arm is so weak, so deficient, that patients sort of deserve the right to try the new experimental intervention. And you end up, and there's many examples of this, we've chosen Afinitor, everolimus in metastatic renal cancer, but you end up with a trial that takes a population relatively late line, so they've already failed some therapies. They're randomized to everolimus or placebo on top of best supportive care, but there's seen to be a clinical or even ethical mandate to allow crossover upon disease progression. So when we compare outcomes of those treatment sequences in respect of survival, we're comparing treatment sequences where everolimus is used in both lines, albeit earlier in one line than in another line, than in the control arm. What do we want to know? What is our clinical question of interest? Well, the clinical question of interest seems to be the effect of, in this case, everolimus on survival times. We can't do that experiment. If you allow crossover, we're not doing that experiment, right? What do we learn from ICHE 9R1? Choice of statistical analysis, choice of trial design should not dictate the estimand. So the fact that I've got crossover doesn't change my clinical question of interest. My clinical question of interest is still the effect of everolimus on survival times. Okay? So I could try and estimate that. I can have a hypothetical estimand as if crossover were not permitted or was not available within the study. I might use relatively complex statistical techniques, RPSFT models, IPCW, whatsoever else. But as you all know, those are methods that rely on untestable assumptions. And hence, in regulatory feedback I've seen addressing this type of circumstance, there's still a preference for a treatment policy estimand, even when we're looking for outcomes, differences in outcomes from those two treatment sequences on survival times where crossover plays an impact or has an impact. That's even documented in the EMA question and answer on adjustment for crossover in estimating effects in oncology trials. There's a lot of text on the screen. Actually, the highlights do seem to have worked here. Maybe you can read through it, but draw your attention to the bottom, that because of the strong and unverifiable assumptions, these analyses may only be useful for regulatory purposes as supportive or sensitivity analyses. So this is, and this is not meant to be a criticism. That's not the point. This is the scenario that Frank was outlining earlier, when even if we have an agreed question of interest, which might be a hypothetical question in respect of that crossover, we might not have sufficiently reliable methods. Let me start again. We might not have statistical methods that provide a sufficiently reliable estimate. So we revert and we perhaps say treatment policy is the right question and the right property to be estimating. It's not satisfactory, right? It's frustrating, but maybe that's where we are with those statistical methods in hand. As a very quick aside, it's highly likely in this type of study design that you have OS as your first secondary endpoint. And if you're testing based on treatment policy question ITT analysis, you're going to fail. Yeah, if the drug is effective in both arms, you're not going to show superiority. That kills your hierarchical testing. Feels unfortunate. I can't cope with this. just as an aside, sometimes this situation with crossover in the oncology studies actually reflects the comparison of a treatment sequence of interest and an existing treatment sequence. It might be that that the drug has already been licensed in third-line use, for example, and we want to test it in second-line use. Then the crossover is comparing two treatment policies or two treatment strategies that could be relevant to clinical practice, which is not the case in the first part of the example where Afinitor is not used. It was never going to be used in that later line of crossover. So there's a subtlety to these crossover cases that it just seems important to note. If you like, why not?
Sorry for this momentary interruption of our program. I don't have an ad.
I could sing a song.
Oh. I do.
Maybe not. Oh. Yeah, perfect.
It's not the one they see.
That's okay. We just go up one.
Oh, yeah.
No.
That's it.
On the drive.
Yeah, but that's right.
No, but
That's
that's not what they see.
oh, okay. No, it's okay. We manage. We manage. Okay, so just to recap, the first example was where we're using an understanding of the differences in outcomes between two treatment sequences. We don't isolate the effect of the experimental drug itself. We're using the differences in outcome between two treatment sequences, one which does include the drug, one which doesn't include the drug, to make sponsor and regulatory decisions about the effects of that individual medicine and regulatory decisions for its approval. But it seems relatively uncontroversial. The second case seems more controversial in that we would like to estimate the effects without the...
Really?
So the second example, we'd like to ask the question, at least in our humble opinions, we'd like to ask the question of the effect on survival in the hypothetical situation where the crossover didn't occur. That's how we're going to learn about the effect of the new treatment on survival times without the quote unquote confounding of its use in the crossover setting, but the statistical methods may not be sufficiently reliable or thought sufficiently reliable to allow us to do that. The third example we've got is, it does relate perhaps a little bit to some of the discussions this morning, but arises in the context of trials that are conducted over a long term in a changing clinical environment. And the idea of presenting this is that it gets us to really think about what is the treatment policy, what is the treatment sequence that's being compared. So we might take examples in liver disease or cardiovascular outcome trials. Again, trials with a changing therapeutic landscape that last over many years. We've actually chosen Alzheimer's disease. You know, it's a neurodegenerative disease where patients will gradually lose cognitive and functional abilities. And we don't choose this because this is so interesting from a regulatory side at the moment with the different decisions taken at EMA and FDA in respect of the anti-amyloid therapies. But there is a new wave of innovation coming after the amyloid monoclonal antibodies, which have different targets. And the anti-amyloid antibodies are gradually being introduced into practice in different parts of the world. So the landscape is complex and the landscape is evolving. Over time, these anti-amyloids might, certainly in certain jurisdictions, become standard of care, but it isn't evolution, okay? So now we talk about a phase 3 trial in Alzheimer's disease to assess a new drug X, which has a different mechanism of action. And we're going to add X to standard of care compared to standard of care alone. Investigators and patients may decide to stop taking the medication and initiate treatment with commercially available amyloid monoclonal antibodies. That can't be stopped, right? The patient has the right to leave the study and take a commercially available treatment if that's what they want to do. But because we're aware of the potential confounding, we might want to specify these as prohibited concomitant medications as part of the study protocol. Of course, that's more likely if the drug is effective that we see this intercurrent event of using another treatment for the Alzheimer's disease on the control arm. So what is our primary clinical question of interest, particularly with regard to the treatment strategies that are being compared, and in light of the fact that the treatment strategy in the control arm is changing over time? At the start of the study, the commercial use of these therapies may be small. By the end of the study, the commercial use of these therapies may be large. There's obviously operational considerations about how we run the clinical trial in that regard. But the fact is, our treatment strategy in the control arm is changing over time. This is sort of importantly different setting than example one, and hence the highlighting of this changing standard of care. Now, what we should do, of course, is to define the treatment strategies we want to compare in our Estimands statement in our protocol. But actually, that's quite difficult to do, or at least what we specify at the start of the trial won't necessarily hold by the end of the trial. A comparison to which control strategy is of interest to judge efficacy and safety and to communicate effects to prescribers. Actually producing an estimate that compares a new treatment pathway to a changing treatment pathway, that would only be interpretable if you really understood how the treatment pathway had changed in the control arm over the course of the study. Otherwise, that estimate is extremely difficult to interpret. And the estimate doesn't reflect any status quo about clinical practice that will exist in the future. Yeah? This is a more common issue than you might initially think. Frank, is there anything you want to add around this example?
No, it's a very good one. It's very good. Just please continue. Thank you for chipping in.
There's an interesting aside to this one as well. As more drugs in the new wave arrive, trials will be increasingly affected by this use of anti-amyloid ABs or this practice becoming standard of care in the control arm. Let's say we have 3 drugs in this new wave with trials started 6 months apart. The last of those trials will be more effective than the first of those trials, right? Those 3 new drugs we're testing might be equally effective, but a treatment policy question won't give us the same estimate for each of those 3 drugs. The treatment policy estimate will get smaller over time. We were discussing in our little group preparing the slides, what do we mean by regulatory consistency here? How do we apply regulatory consistency? Is consistency to always use treatment policy questions, which actually in this instance leads to inconsistency in the type of comparison that's actually made in the end and the estimates that would be produced. And again, how do we retain a meaningfulness of estimates for prescribers in treatment policy questions that are so complicated by that changing nature of the control arm over time? This is the last setting we wanted to talk about in our examples. The previous examples have been based on looking at effects of longer-term outcomes that are impacted by a whole series of treatments, but there are also many interesting discussions for trials investigating the effects of symptomatic treatments, where one might assert, I might assert, that it's preferable to understand the effects of the drug directly rather than the effects of the treatment sequence. So it's preferable to try and estimate the effects of the experimental drug itself rather than the effects of a treatment sequence that include that experimental drug. I'm going to assert that that gives a better basis for regulatory decision-making and better information to prescribers. And by the way, I bet everyone here has been involved in a protocol that chooses patients whose medical condition, background treatments are not only been stable for the last 3 months, but are expected to remain stable for the next 3 months. Why do we do that? We do it to isolate the effect of the drug, yeah? So I assert that in clinical trials, comparing drug to no drug can be attractive, and indeed, there's benefits to superiority trials over non-inferiority trials that I don't need to explain to this audience. So our example here is, and you can't see it because it's off the bottom of the slide, but our example here is of drug Z, which is a symptomatic treatment. Scenario A, the experimental treatment's not well tolerated. The fact that it's not tolerated means that patients switch early from the treatment arm to a rescue treatment. So let's say 50% switch, 50% remain on drug. Whereas in the control arm that doesn't have the tolerability issues, 10% switch, 90 remain on placebo. We ask a treatment policy question and we show a nice big effect size and a demonstration of superiority. Who wants to license that drug? That's a comparison of the treatment sequences, treatment policy question, ITT principle adhered to, et cetera, et cetera. Who wants to license that drug? Well, you might, but it's not obvious, is it? So let's switch it round now. The experimental treatment now is tolerated. 10% switch, 90% remain. On the control arm, 50% switch to effective rescue because of a lack of efficacy, 50% remain. Now we show superiority. Who wants to license that drug? Very possibly so, right? But is the treatment policy question of interest for approval, and is the associated estimate interpretable to prescribers? We're going to try and answer that over the next couple of slides. Is the treatment policy question of interest for approval? Yes, because it's conservative. This word was mentioned 2 or 3 times on the panel discussion this morning. It's good because it's conservative. Conservative compared with what? What's it conservative for? What I think we're saying is that the impact of the rescue medication making the outcomes better in the control arm means that the effect size would be smaller than if that rescue medication wasn't there. I think that's what we mean by conservative. But actually, if we're interested in the drug versus a control arm that doesn't have the rescue medication, why don't we ask a hypothetical question? That's what this language and this framework now allows us to choose. If that's what we're genuinely interested in, and we're only going to something because it's conservative in respect of that quantity, why don't we just ask our estimand in respect of that quantity? Is the associated estimate interpretable to prescribers? Well, arguably, only if the prescriber knows the rule for using rescue and how many patients use rescue and when. There's a very famous, or at least in my mind, famous study in a respiratory condition where a triple combination was being compared to a double combination with the possibility for patients on the double to escalate and use the triple if their lung function deteriorated. Guess what happens? You compare triple with triple. Yeah, very difficult to interpret the estimates from that. The point being that if we had a protocol with a different rule for the use of rescue medication, we'd get a different estimate of effect under a treatment policy question, right? The drug's equally effective. It might be tolerated and by the same number of patients might benefit, but a different rule for the use of rescue medication will lead to a different estimate of effect under a treatment policy question. Is that then a good way to estimate effects and communicate them to prescribers? And does this promote sponsors running slightly artificial studies where the treatment effect is going to be maximized by the choice of patients and experimental conditions, etc.? But we don't like hypotheticals, right? Because hypotheticals do not reflect clinical practice. Well, perhaps they can. I think there are some intercurrent events that are caused by the fact that the patient's in a clinical trial, and they wouldn't happen out there in the big wide world in clinical practice. But I think, as we've been saying, we shouldn't assume that a treatment policy question necessarily does reflect clinical practice. We have that third example of where the treatment sequences that would be used in practice are changing over time. And of course, in this context where we're in placebo-controlled trials trying to understand the effect of a drug, the fact that we have a placebo does not reflect clinical practice. In clinical practice, we don't take the patient with migraine or the patient with hypertension who meets our inclusion-exclusion criteria and say, go away for 12 weeks, just come back if it gets a lot worse, and we'll initiate treatment. That's not clinical practice. So our estimates from placebo-controlled trials oftentimes don't reflect an estimate of treatment effect that applies to clinical practice. There's this text that I think is really important to read and think about from ICHE 9. It's in the middle of the screen. In many clinical trials, the use of the full analysis set provides a conservative strategy. That's what we've been talking about, the word conservative. And then under many circumstances, it may also provide estimates of treatment effects which are more likely to mirror those observed in subsequent practice. I never read that sentence and gave it much interest, years ago. Now, I really don't like that last sentence. I think it's pointing to the fact that patients will discontinue treatment in practice as well as in clinical trials, and treatment policy questions in respect of treatment discontinuation may make very good sense. But actually what it says is estimates of treatment effects. So that's experimental arm versus control arm, right? And our control arm in these studies does not have anything to do with clinical practice. And again, for very good reason. So the treatment effects we estimate don't mirror those observed in subsequent practice. There's lots more we could have reflected on, but time is ticking. There was an interesting discussion about terminal events this morning, treatment discontinuations, but let's just wrap up. A clinical trial might aim to compare treatment sequences or might aim to learn about the effects of an individual drug. Both might be valid, either might be valid, but they are importantly different clinical questions of interest. Do you want to learn about the impact of putting a drug into a treatment sequence, or do you want to learn about the effects of the drug itself? They are importantly different, and your Estimands considerations would be different. The point of this talk is not to argue against treatment policy questions, of course, but to highlight that defaulting to this because it seems more statistically nice and easy is not trivial and does give rise to a number of issues that we want to highlight for consideration and encourage reflection and discussion. As has been said a number of times, this trade-off between uncertainties in estimation and the true clinical question of interest, more weight at the moment is given to reliability of estimation. We make our choices of Estimand based on what we think are the properties of estimation, which is not necessarily in line with the guideline, is not necessarily getting us truly to talk about the clinical question of interest. And consistent with that, the discussions are often only amongst statisticians and not other disciplines. There was a comment this morning that the Estimand most valuable for regulatory decision-making and the Estimand most informative for prescribers might differ. I think that's really important. I so wholeheartedly agree with that. And the Estimand and the estimate on which a regulator is prepared to say this drug works is not necessarily the same Estimand as you want to communicate effects to prescribers. So we think we hope to have illustrated not only the interesting questions that might arise, but the fact that the Estimand framework gives us a basis to discuss fundamental questions about why we do clinical trials and what we learn about our drugs. And that's back to the title. The Estimand framework's been implemented, we're all doing it, but its potential hasn't been achieved because we're not using it to get to the heart of these questions of what we really want to learn about our medicines. Thanks. I'll let you.
Thank you very much, Rob and Frank, for this great presentation, setting the scene, and sorry for the technical difficulties. So as we said in the beginning, we will continue with the next talk now. Our next speaker will join us virtually. This is Mia Paterniti. She is a clinical team leader at the Division of Pulmonology, Allergy and Critical Care within the Center of Research and Drug Development within FDA. Mia has been working and presenting on Estimands for several years, and today she will provide us with the clinical perspective on implementing the Estimand framework. So Mia, I hope you can hear us, and over to you as soon as you can see the slides.
Thank you, Vivian. Can you confirm audio? Can you hear me? Can you hear me?
Yeah, we can.
Oh, wonderful. Fantastic. Thank you so much for that introduction. Good afternoon to everybody. I very much appreciate this invitation to participate in the important session today to provide clinical perspectives on Estimand framework implementation. Next slide, please.
Just a moment, please.
No problem.
She sees the slides.
We currently have issues here in the room. I will let you know once we have solved this issue here. So we are back, Mia. Over to you again.
Wonderful. Thank you so much. Okay, so I'm presenting my personal views and opinions, and I am not conveying official FDA policy, and no official FDA support or endorsement is provided or should be inferred. Everything I'm discussing today is available in the public domain, and I have no financial conflicts. Next slide, please. Great. So I'm going to begin today by touching upon some of the benefits of productive interdisciplinary collaboration. My primary focus today is to really support the collaboration between clinicians and statisticians as we work through the Estimands. I'm going to spend the majority of the time on the challenges of implementing the Estimand framework. I will touch upon the clinical question of interest as well, and I'll close by discussing the impact of the Estimand framework on the regulatory process. Next slide, please. I think one more click. It is important that clinicians engage in Estimands. We are very imperative to aligning the Estimand with the clinical question. Oftentimes, when clinicians hear Estimands, they think that it's statisticians in the statisticians bucket, but it's really important to continue to discuss the importance of the clinician's role. And the more we hear it, the more I think that promotes engagement. So Estimands, as you all know, describe a treatment effect of interest, but if the Estimand doesn't align with the clinical question, then the treatment effect doesn't answer the question. And so by collaborating with your clinical teams, this does help to align the clinical question and the Estimand, and this does rely upon efficient and effective engagement between both clinicians and statisticians. So the methods to accomplish this include accounting for intercurrent events that occur after random assignment that may affect assessment of the treatment effect, as well as the varied patient journey. Ultimately, by aligning the clinical question and the Estimand, we're able to better define the benefits and risks of treatment to support regulatory decision-making. Next slide, please. So this first step where the clinical question is formed and is then translated into the Estimand is really the part where the collaboration is critical. This translation of the clinical question to the Estimand really relies on working together with your clinical teams. Ideally, clinicians will engage in identifying that clinical question with your assistance, and then the statisticians can aid in clearly defining the Estimand terminology to lay a foundation for efficient discussions to translate this clinical question into the Estimand. Next slide, please. So as we've been working through the Estimand framework, we have identified several challenges. You've previously heard about some of the challenges that have been encountered, and I'm going to go into a few more. So there has been a steep learning curve, and I think we've learned a lot. However, there remains to be a knowledge gap around estimate terminology, and I think that's more so on the clinical side than the statistical side. It's almost a new language, and I think that when clinicians are going through this learning process, it's really important to have the statistical support. Also, statisticians are learning about clinical context in order to create a more nuanced understanding of how to address the intercurrent events. In addition, each clinical trial design and therapeutic area introduce new challenges. So one challenge that comes up often is how to implement composite strategy to reflect an unfavorable outcome on a continuous endpoint. I'm sure everyone has struggled with that. And there also may be more than one way to approach intercurrent events. So we're attempting to learn as we go. by exploring the effects of intercurrent event strategies in supplementary analysis to inform future trials. And I think that's why we also need to be having these discussions very early on in order to go forward into phase 3 with information that's important to inform the estimands for these trials. Next slide, please. So I'm going to go through each of the challenges that I just laid out in a bit more detail to kind of unpack some of the layers behind where the struggles have really been. So since the birth of the Estimand framework, clinicians have started to become more familiar with certain Estimand terminology. For example, treatment policy, as was mentioned previously, there's a lot of discussions about this. Most clinicians have an understanding of what that means. In addition, composite strategy is often discussed, so there may be some understanding there as well. However, less commonly used strategies like principal strata may require reminders and additional support and discussion when considering that strategy for your estimand. It can also be helpful to tie when you're first discussing with the clinical teams, trying to sort of iron out some of these basic concepts. It can be helpful to tie it back to more familiar terms, like the ITT principle. So for example, when discussing treatment policies, framing it within the ITT principle may help to lay the appropriate foundations for more efficient discussions, although acknowledging that the link between the two can depend on the context. But conceptually, it can be useful to sort of to tie what people already know to this new concept. Another common issue that I think comes up as we sort of have these discussions and these misconceptions start occurring is the deciphering between missing data handling and intercurrent event strategies. So it's useful to explain at the onset of some of these discussions the difference between these two so that there is no misinterpretation, and to really try to explain how these differ. Finally, I have found that reframing intercurrent event strategies into a clinical question can be useful ways to communicate with clinicians. So if you sort of translate it into clinical language, that can also help for clinicians to engage in what the problem and potential solutions might be. So I'm going to provide some examples of this on my next slide. Next slide, please. So if your clinical team needs more understanding of how the treatment policy would be, how that could impact the clinical question, you can frame the policy within a clinical question. So for example, what is the effect of the test treatment compared to control, regardless of whether the intercurrent event occurred? An example, if treatment discontinuation was your intercurrent event, you could say, would you be interested in knowing the effect of the drug regardless of whether treatment discontinuation occurs? So sort of forming it within a clinical question can help clinicians to engage with what the impact of choosing that strategy may be. For composite strategy, you could ask, what's the effect of the test treatment compared to control, reflecting an unfavorable nature of the intercurrent event on the interpretation of the outcome. So for example, if death was the intercurrent event, would you want death to be reflected in the endpoint assessment? And if most subjects died in the trial, but the effect was only assessed in patients that lived, would you reflect that? Would that reflect the clinical question? So those are some of the ways that it might help to approach the clinical team and speed up the understanding of the impact of these strategies. So I've often found that reframing the strategy in this way can lead to effective discussions with clinicians. Next slide, please. So I've listed here some of the common steps that we consider when we're defining the estimand. And these steps, including, of course, the first step, identifying the clinical question, each of these steps have to be considered with not only within a therapeutic area, but often for each development program. And it's really important to make sure that all of these steps align with the clinical question. So across therapeutic areas, these can differ. Within a development program, these can differ, and the intercurrent events within a development program might be the same, for example, if you're studying one specific disease, but the strategies that you assign with across studies could be different, and the implementation for those strategies could also be different, which adds complexities and increases the need for discussion. For example, if you had a trial looking at the same disease, but one trial was assessing efficacy using a continuous endpoint and the other using a dichotomous endpoint, then implementation of, for example, the composite strategy would be different. So really engaging at each of these steps for each of the trials is important and does require engagement from both sides. Next slide, please. So I've listed here a slide that some people may be familiar with, but these are really some of the common intercurrent events that we think about for clinical trials. But as you consider each of the trials, you really have to assess which of these intercurrent events should be accounted for based on the patient journey. And these can differ across trials, even within the same disease areas. For example, if there were two trials that evaluate different severities of the same disease, where, for example, one trial might be looking at a first-line therapy, and the other trial is looking at add-on to standard of care, the milder disease study may not consider a change in background therapy as an intercurrent event. Also, some of these intercurrent events may be more important in specific therapeutic areas. For example, if you were studying a disease where death was a common outcome, you would need to ensure that death was adequately accounted for in your estimand. And the same could be said for rescue meds. So some disease areas commonly use rescue meds for exacerbations, and that can impact the conclusions on efficacy, as has been mentioned before. I think really thinking through each of these is very important in the estimand process. Next slide, please. In addition to thinking about the appropriate intercurrent events based on the patient journey, there may be multiple layers to consider for each of these intercurrent events. For example, if a treatment discontinuation can occur for multiple reasons, and the reason may impact how you handle that intercurrent event. For example, treatment that's discontinued due to an adverse event may impact efficacy conclusions differently than treatment discontinuations due to lack of efficacy. It's also important to consider the reason for treatment discontinuation is clearly justified given these differences. Another complicating factor is that intercurrent events can overlap. For example, one patient can discontinue treatment due to lack of efficacy and also switch to a different treatment. So these complexities can add additional challenges when discussing intercurrent events. Next slide, please. So often you may need to think outside of the common intercurrent events and consider intercurrent events that are disease specific. For example, if some diseases require corrective surgery, this can impact efficacy outcomes and need to be accounted for. And these unique intercurrent events require knowledge of the disease-specific patient journey and often require discussions with clinicians to identify these intercurrent events and to adjust for how they will impact efficacy in terms of just using the appropriate strategy and implementation of the strategy. Next slide, please. So you've identified your intercurrent events, you're feeling confident that this is that you've been thorough and thoughtful. And now the next step is trying to think about the strategies for each of the intercurrent events. And this can be difficult. There, as has been discussed at great length, there is treatment policy may be favored by many, but it's not always straightforward. It can be complicated if there's a high amount of missing data Composite strategy can be challenging. As I've discussed before, if you're trying to decide the assigned data value for a continuous endpoint. And hypothetical strategy can be complicated if there's uncertainty in ascertaining whether the situation where the intercurrent event would not occur is specific and relevant. Also, assessing whether the imputation strategy is sound and reliable may not be clear. So overall, because of these challenges, exploring the effects of different strategies in supplementary analyses is often useful in terms of gaining knowledge to inform future studies. Next slide, please. So I would like to close today's talk by acknowledging the strides that we have made since FDA's implementation of ICH E9R1 in May of 2021. We are learning how to support close collaboration between clinicians and statisticians to align the Estimand with the clinical question of interest, as we recognize that Estimands have direct impact on both drug approval and labeling claims. Our common goal is to derive clinically meaningful and statistically appropriate Estimands to discuss with sponsors more efficiently and effectively. Next slide, please. At FDA, we have been considering Estimands across multiple aspects of our regulatory work. Cross-discipline collaboration has resulted in several published guidances that discussed Estimands over several therapeutic areas. Some guidances provide specific Estimand recommendations, such as the chronic rhinosinusitis with nasal polyps guidance and the graft versus host disease guidance. I would like to point out that the graft versus host disease guidance provides specific examples of an Estimand which starts with the clinical question of interest. Other guidances provide general Estimand guidance, for example, that the description of the Estimand should reflect the clinical question of interest with respect to intercurrent events. And the guidances also remind sponsors to provide adequate justification that the proposed Estimands address meaningful clinical questions of interest. In addition to incorporating Estimands in our guidances, we've also systemically considered the Estimand framework during investigational new drug reviews and new drug and biologic application reviews. To support these myriad endeavors, the Office of Biostatistics has provided support across divisions and offices through their Estimand framework working group. We look forward to continuing to expand the Estimand framework throughout the regulatory process, and I appreciate your attention today. Thank you very much.
Okay, now we come to our last presentation by Laura Rodwell. So she's a statistical assessor at the Dutch Medicines Evaluation Board since 2016, with a special focus on the assessment of oncology products. And she's also currently the co-lead of the Estimand Implementation Group of the European Medicines Regulatory Network. And this implementation group has members from EMA and also from different European national agencies. So Laura, please.
Thanks, Andreas. So I'm going to be talking about the other end of the Estimand definition. So we've been talking a lot about, the time when we're talking about scientific advices and perhaps before the study's been designed. But this is more a consideration in the context of the assessments that we actually do. Okay, this one. So these are my personal views. So just to give a bit of context, I didn't want to make too many assumptions for you all. Just wanted to give you a bit of an overview of the centralized procedure and how it works for us at the Medicines Evaluation Board. So the Medicines Evaluation Board, as a rapporteur or co-rapporteur, Netherlands being the one of those two, We usually have two clinical assessors assigned to a procedure. So one looks at efficacy and one looks at safety, and they peer each other. And then there's one statistical or methodology assessor who really contributes mainly to the clinical efficacy part. But we can also, we also look at other sections if necessary. The clinical assessors tend to take the lead in the assessment, but as methodology assessors, we contribute wherever we see is necessary. So the important reports and documents for our assessment, most important kind of time period is certainly this up to the day 80 clinical assessment point. This first clinical assessment report is really the most comprehensive assessment that we do. So we look at everything like the study design, the estimand, if it has been defined, and of course the results, and make kind of comments and assessments of those. And of course, importantly for the evaluation of the benefit risk, this draft overview and list of questions then gives this kind of more, I guess, concise, I don't call it concise, but evaluation of the important aspects of the assessment. And the most important part is essentially the discussion on the benefit risk of the product. And then, of course, the list of questions that you are probably quite familiar with in order to resolve these uncertainties for the benefit risk. And as the process goes on, then kind of this assessment report or this overview then evolves into the essentially the European Public Assessment Report after the CHMP opinion has been made. And then, of course, the all-important product information, or SMPC, is also a consideration of the assessment. And in the context of assessments, given the studies are already been done, we either see procedures where the estimand has been defined or it hasn't, scientific advice has been requested and provided or hasn't. So essentially, we're working with what we've got. So based on that, this is how it started in terms of the assessment. And I'm thinking more in the lines of the clinical assessors, but also, let's face it, also the statistical assessors when first faced with this Estimands addendum. I think as statistical assessors, we got a bit more quickly into our comfort zone. I think it's kind of our way of thinking, and it really matched with, I guess, a way to try and resolve the issues that we had. And I think the challenge for us was really kind of stepping into this role of a trainer, a translator, a facilitator, to try and get the clinical assessors also on board and understanding. And also, I think I think in terms of scientific advices, it was very clear how this process was going to start, because that was really the goal to discuss up front. Then I think the role in terms of the actual assessment was a little bit unclear, like how we would actually handle the estimand in that part. So in terms of how it's going, there's still, and mainly considering the clinical assessors and how we work with them, I think there's still some, I guess, anxiety and confusion, but the clinical assessors, as Mia mentioned also, really recognize the importance of the Estimands framework, and they're really becoming more engaged in the discussions and really willing to be part of this discussion. I mean, for the assessment, there's still some challenges and sources for confusion. I think one of the ones that I've been, I guess, philosophizing over is this idea of the comparisons with the previous procedures. So clinical assessors, especially, have a very good memory, and if they don't remember something, they have access to previous procedures. And they do aim for fairness and consistency. So I think that creates a bit of a dissonance in the sense that if you're really thinking about your clinical question of interest, and perhaps it's different from what has been published in previous EPAs for similar procedures or SMPCs, then at the assessment stage, it's really quite a difficult, I guess, discrepancy to resolve. So I think in that regard, it's really, we kind of need either a guideline or a clear scientific advice or an important discussion at the CHMP to really be able to make those changes and to be able to bring those kind of, if we have a more preferred clinical question of interest into that assessment. The role of the statistical assessor versus clinical assessor, I guess it was always a little bit overlapped, but I think with the Estimands, it's actually becoming a bit more of an overlap. And I think the role of the statistical assessor in terms of describing the Estimand and having those related discussions in the assessment, I think I've got the question of whether we're actually kind of reducing the learning opportunities by doing the work. I think we do tend to be the ones that give this reflection on the Estimand and have that full assessment. As I mentioned, I think our role changes in a little way in the sense that we have to step up and really try and help the clinical assessors. And I think for not all statisticians might be comfortable in that sort of role. And I think it's a whole new, different skill set for us. And also, considering there's kind of this difference between the sensitivity analyses versus supplementary analyses, especially if the Estimand hasn't been defined, we tend to perhaps these so-called sensitivity analyses are actually addressing a different question of interest. So then it's a bit of a question of how we actually kind of bring that into the assessment and to what extent we really kind of have that discussion. And this is also quite critical when perhaps one of the sensitivity analyses is our clinical question of interest from the EMA or CHMP perspective. And so in terms of reducing the barriers for clinicians, training and education is obviously a first step. So we have been running workshops within, MEB and I think other NCAs, and there's a plan for network-wide training early next year. And what I like is that there's also some move to include the Estimand in university education. So Kit and Eisen, who work at a medical center in the Netherlands, actually have introduced the Estimands into the biomedical sciences master's course. So that's kind of this idea of really kind of teaching them young, and maybe one day we'll have a clinical assessor turn up saying they totally got the Estimands covered. So we'll see. And I think really this kind of being able to expose the clinical assessors more to the scientific advice discussions and examples. Within the Medicines Valuation Board, our methodology group gets together once a month to discuss the scientific advices, and really the most fun, I'll use that word again, discussions have been around kind of the Estimands and kind of thinking about intercurrent events and what kind of strategies we would advise. But we've never really kind of made the decision to also include the clinical assessor in that discussion. So I think that's something that's quite a nice move for us to do. And then they just get more exposure. It's really, I think that on-the-job learning is really quite critical for this. And of course, making it more relevant for the clinicians. I think what Mia presented are really nice, relevant questions. And I also find the why is also quite nice to bring in. So for example, we had something recently where a particular rescue therapy was only considered one if it had been used for at least 3 days. And for me as a statistical assessor, that doesn't really mean anything to me. So then the clinical assessor, so I asked the clinical assessor, why 3, why not 2, why not 4? And then of course you gave the response that that's really kind of the amount of time that it would take for this other therapy or other medication to take effect. So I think those kind of the whys, which really brings it back also to the clinical question of interest, might help. So in terms of how it's actually going with the assessments, what I did, I thought I'd let the numbers do the talking. I'm mostly in oncology, so I have quite a biased, perhaps not so positive view of how it's going. So I did a mini review, and I looked at the approved medicines between the start of 2023 and May 2024. And this was based on the European Commission date. And I excluded, I really just focused on the kind of new approved products. So I excluded extensions of indication, biosimilars, etc., just to keep it simple. And I searched both the European Public Assessment reports and the SAPN protocol of the relevant procedure. And then searched on the following terms. You may notice that I missed out on the principal stratum term. I didn't really feel it would be here. So such a good use of my time to search on that one. And so for both the EPA and the SAP, I looked at if there was any reference to the Estimand based on the terms above. And of course, within the context of being related to an Estimands discussion, and if the Estimand was defined in full and either in a table or words. So this is what I came up with. So there were 57 approved within that year and a half, so up to June 2024. So within the SAP and the protocol, 24 of those, so just over 40%, included Estimand-related terms. And 18 of those had a fully defined Estimand. So I guess if it's mentioned, then it's actually pretty nice. And of course, when I saw these numbers, I kind of realized, of course, thinking back to that, time frame for the centralized procedures, January 2023, like if you think back that, of course, it has to be submitted and assessed. So then you're looking at, probably around a year for it to actually be submitted. And then, of course, you've got all the time to actually do the studies and get the submission together. So perhaps we need to be a little bit more patient to actually see things fully into effect for the actual assessments. And so I also looked at, of these 24, I also looked at what was included in the EPA. So 17 also had an Estimand-related term mentioned. And I was actually quite surprised to see that 7 didn't actually mention the Estimand, even though it was referred to in the SAPL protocol. I think that might go back to maybe a need of maybe some rapporteurs kind of look back and try and be consistent with how they've reported. But I think that will certainly change over time and improve. And then there were 33 with no Estimand-related terms. Some of those EPAs did bring up the Estimand, but that was really in the context of the assessment, perhaps asking for additional data, additional results. And 3 actually had a fully defined Estimand. So that was either, one was, I think, inferred, and the other one, the rapporteur requested the Estimand to be defined as one of the list of questions. So I'm not sure if you're aware, but in our day 80 clinical assessment report, we now have a Estimand table. So I think those, I think that will certainly improve at least the reporting of the Estimand in a table or a text form. As part of the assessment report revamp project to try and get a bit more consistency in the EPAs, which is always a good thing. So then the rapporteurs will then fill in this table, and it also includes a request for a plain language statement of the Estimand and guidance for the rapporteur's assessment. Also thinking about whether it's justified, is the strategy also justified? So ideally, this would be something we could take directly from the protocol, but we'll see how that goes. So now I just want to consider 3 assessment scenarios that I see. This one is where kind of everything comes together. Let's say it's so at the time of the study design, the scientific advice was sought. It also included a comprehensive discussion on the Estimand attributes. So there was a question asked, and the assessor really gave quite a comprehensive discussion on that. And there was also some disease-specific EMA guidance with a discussion on the Estimand. So, in terms of that, in terms of having a good definition at the time of the study design, that was all there. And the Estimand aligned with our scientific question of interest, estimation aligned with Estimand. And what I really liked about this was there was also actually a listing of intercurrent events by patient with the date and rescue therapy used. And I think this is probably the only time I've seen this, and it's really something, I think, of appreciation for the statistical programmers in terms of bringing that into what would otherwise, I guess, be quite standard for them. So before I complain about not getting those that information, I think it's good to acknowledge that it's actually quite easily said that this is that this can be made available, but it's not so easily done. And I know that there's a working group working on this to see, essentially it starts with being able to define what you need to collect and then bringing this into the ADAM data set, etc. So I think it's very much appreciated, and I hope we do see it more in the future. Assessment scenario 2 is actually, by total coincidence, the same as hot topic 2 from this morning, about where the Estimand's been defined, but new challenges arise, and new being kind of missing data, but in the context of trying to understand what that means for the treatment policy estimand. And the questions that arise during these kind of assessments is, essentially what do we know about the patients who don't have complete visit data? Which, if any, intercurrent events are recorded for these patients? When did they occur? So it's all this information that will help us kind of, think about the assumptions that are made and the plausibility of the assumptions that are made. And of course, the question of whether the standard MMRM model is unbiased. And also, funnily enough, I also wanted to acknowledge that the various working groups that are in place for the Estimand also really help us as assessors, because I did rely on this article to really think about what could we ask as a reasonable additional analyses, and what should we expect, and when might things be unbiased. Finally, assessment scenario 3. This is when the Estimand hasn't been pre-specified, and the example in oncology for progression-free survival. So progression-free survival is quite stubborn in the sense that in terms of switching to the Estimand, I think it still has a preference for censoring rules. So typically in the primary analysis, if new anti-cancer therapy is received before centrally determined progression, then the patient's to be censored. But discontinuation of treatment alone is not a reason to censor. And then the sensitivity analysis tends to be presented with no censoring, and this is or the EMA preferred approach according to the current guideline. So the challenge here is whether we should translate the censoring rules to the Estimand language. I personally prefer that because it helps me really I feel like actually presenting the issues and talking about the issues in the assessment is helped by the Estimand language. And then there's a question of, can we, as the EMA or CHMP, get an answer to our question of interest? In some cases, these patients who receive new anti-cancer therapy aren't followed up even according to the protocol. And then, of course, there's examples where patients may just choose not to continue with assessments. And that really challenges us, because then we end up very quickly with a request for sensitivity analysis, including tipping point analysis, which is quite a discussion point in CHMP these days. And it's challenging for us to ask the right questions, probably just as challenging to answer them from the industry side. And indeed, as we were talking about earlier, an evaluation really requires understanding the plausibility of these assumptions, and that is really quite a challenge, especially when we're really trying to think about what the treatment effect for our question of interest might be. Finally, just wanted to emphasize the importance of these early interactions through either guidelines or scientific advice. Let us have the fun discussions on the Estimands and bring the clinicians into it. Thank you very much.
Thank you very much, Mia, and also Laura, for both of your talks. We would now like to invite all the speakers and also the panelists who are in the room to come on to the stage for our panel discussion. And we will also have Frank, of course, and Greg and Mia virtually joining the discussion. We will start with a few statements by each of the panelists, followed by a panel discussion which is guided by some predefined questions to really have a focus of the discussion and not have like everything on Estimands. But we invite the audience and also the virtual participants to engage, asking their own questions, ideally in line with the focus that we have outlined here. But of course, we will broaden up the discussion later on to make it really something of interest for all of you. And because you're standing there, please come to the stage. And I perhaps start with you, Greg, as the virtual panelist. So we have Greg Levin with us, who is a supervisory mathematical statistician at the Center for Drug Evaluation and Research within FDA, supporting the regulation of products across a range of therapeutic areas for more than a decade. Do you have anything to add or any statements you would like to make, Greg?
Sure. Can you just confirm that you can hear me okay?
We can.
Okay, great. Thanks very much for the invitation to participate today, and thanks to the speakers for the really nice talks. I mean, I agree with many of the core messages in the presentations. I think there's a tremendous opportunity and there's tremendous value in the Estimands framework. But at the same time, I do agree that there kind of remain some important gaps in its implementation. In that light, I'm hoping we can work to develop some core principles that should be followed when implementing the framework. And I think discussions like what we're going to have today is, can go a long way in that regard. There's still going to, of course, need to be challenging cross-disciplinary discussions and judgments made in individual drug development program settings. But I think a set of core principles would likely help address many of the challenges that have been raised. And to kick things off in that direction, I thought I would propose one core principle that I think is important, although perhaps a bit provocative, a bit controversial. And the principle is that clinical trials should ideally be designed to provide information that's relevant for informing actual treatment decisions by patients and prescribers in real-world clinical practice. Such trials, if they're designed in that manner, also help us understand the potential public health impact of introducing a new treatment to clinical practice. By proposing this principle, I suppose I'm kind of answering one of the questions that was posed in Rob and Frank's presentation about whether there's a tension between the design and analysis of trials to support regulatory decision-making and to inform patients and prescribers. And I guess my answer to that is no. Let's remove that tension and try to align them, is where I'm kind of going with that principle. And the first major consequence of trying to achieve this core principle is that patients on the control arm of clinical trials would ideally receive a reasonable representation of current local standard of care. And, of course, this is not common practice in many symptomatic diseases where there are approved, safe, and effective therapies, in which trials often utilize a placebo-controlled design in which participants are withheld those available therapies. When we have those designs, control arm participants don't receive a representation of standard of care. The trial is not targeted to informing real-world treatment decisions. And then there are lots of estimate challenges that arise because we're conditioning on that design. And I think that, example number 4 in the presentation by Rob and Frank really highlighted some of those challenges. But I think they can largely be mitigated with a different design that includes a standard of care control arm. So I think we'd have to dig into that a lot further, and perhaps we'll do that in the panel discussion. But I think depending on the setting, this could lead to more active control trials, either superiority or non-inferiority designs. This could lead to more add-on trials in settings where the therapy might be used as an add-on to available standard of care therapies, but it would depend a lot on the specific setting, how that translates into a specific design. A second consequence of this core principle is that we would only be interested, or we'd only be primarily interested in hypothetical strategies for intercurrent events when the envisioned hypothetical scenario reflects a circumstance that's actually plausibly expected to occur in the real world in the future. So, for example, it was very sensible in trials impacted by the COVID pandemic to target an Estimand with a hypothetical strategy for handling treatment interruptions or treatment discontinuations due to pandemic-related operational reasons. This was, very well justified because it was providing information, or it was trying to provide information relevant to actual treatment decisions in a future world in which the pandemic-related operational impacts would not be expected to occur. But in contrast, when we're talking about hypothetical scenarios in which all patients will adhere to the treatment, or in which some additional medication that is part of standard of care will not be available, these are hypothetical scenarios that likely do not reflect plausible clinical practice scenarios, and therefore, in my mind, are of less or of questionable interest. So that's just, trying to get things started with a provocative principle for discussion. I'll stop there and thanks again for the opportunity to participate in this session today, and I'm looking forward to the panel discussion.
Thank you, Greg. The next one would be John Johnston. John is a clinical assessor in the biologics unit at the UK's Medicines and Healthcare Products Regulatory Agency. And he asked me to say that his first contact with a statistician was actually in 1979. So over to you for some statements.
Okay, thank you. Just by way of explanation, I started in science, whereas you heard I had a contact with a statistician, and he and I and two others published a paper shortly afterwards based on our discussions. I then moved into general medicine, where I became a fellow of the Royal College of Physicians. So I've had exposure to many different types of clinician. And I've now moved into pharmaceutical medicine, or what's called in my country pharmaceutical medicine. That's a very niche area of medicine. There's few people in that. And beyond that, I'm in regulatory science, so there's even fewer people in that. Because of that, I see things differently from statisticians. So I'm going to give different views from the views you may have heard from the statisticians here, but also I see things differently from the clinicians. Okay, there's no such thing as a clinician. They're all got different views. If I'm given the opportunity, I will describe the model that I work to. Okay, and some of the things I say you might find curious, surprising, and difficult to accept. But whatever I say, please be aware it's comment only. Okay, I'm not here to batter you about the head and say you must do it my way or whatever. It's just comment only, and you can either take it or leave it. It's just comment. I also want to make the point that, like many of you here, English is my second language. So up here, I'm having to translate, back and forward. My problem is that in so doing, what you hear can come across as rather blunt and rather rude. So let me just say now, if that happens, please accept my apologies. I didn't mean it, Gov. Thank you very much.
Thank you, John. So our last panelist in this round is Florian Lasch. Florian Lasch is a biostatistician supporting the evaluation of medicinal products at the EMA. And Florian, as we already heard today, co-leads the estimate implementation group at the Medical Methodology Working Party together with Laura. Over to you, Florian.
Thank you very much. I took quite some notes during the previous sessions and then the very nice presentations, and I'm going to try to link some of the themes that I've seen, and like to take this opportunity now, celebrating 5 or 10 years of an Estimands anniversary, to take a bit of stock and then also think ahead. What do we as statisticians still need to do? And the first link that I saw was with Kaspar's presentation, talking about what are the relevant metrics for estimates implementation. And I'm going to try to kind of touch upon some of these briefly. And the second point was, Rob, you mentioned estimates implemented, but the potential not fully freed up. And I would fully agree to that. So what is missing to really use estimates to their full potential? And structuring the kind of methods, same as the estimates concept, we have the estimate level, and then we have the estimator level. And I'm going to share some considerations for both. So on the estimate level, we have seen in the presentation and also with the nice examples from Laura, estimates are being used, not always, but they are part of the discussion. We've heard that they are part of FDA guidelines. They are part of EMA templates and also some clinical guidelines. So we seem to have come a long way. But estimates are still very much owned and that's based on my personal experience and also the discussions I've had in the coffee breaks and at other conferences, very much owned by statisticians. Sometimes there is a bit of discussion, but statisticians are mostly seen as responsible for the estimate and the owners of the respective sections to bring the topic up. And I think here we really need to work towards a kind of a governance model where clinicians feel and regulatory colleagues feel that they are responsible and statisticians are facilitators and consultants in that discussion. So I think that would be my metric for the estimates level. On the estimator level, and I think also partly due to our strong focus on the conceptual level, which is understandable because it was new, we needed to understand it, we needed to teach others. I think there has been less work done. We have seen some work from Tobias, for example, missing data handling after treatment policy strategy for a single intercurrent event. But we've also heard that for crossover, there isn't a good estimator, which is restricting our choice and estimate. What happens if we have 2, 3 intercurrent events handled with different strategies, complex pattern, how they co-occur? We as statisticians don't have the solution for that. And I think that should be an area where we focus on, which is our core competence. And I think where we need to provide the solutions because no one else would. And does this mean this is a stats topic only? No. But I think here the roles are reversed. Statisticians really need to be in the lead to develop and evaluate appropriate methods and have clinicians at their side that can consult them what is clinically realistic in this setting, what is plausible, under which data generating mechanisms do I need to evaluate the performance of my proposed methods. I think that's the co-ownership model that I'm seeing here. And that would be the relevant metric to work forwards, maybe for the next, until the next milestone. And then we see where we are.
Okay, thank you very much for our panelists for their statements. So now we want to start the discussion. So I want to invite the whole panel either to comment on what has been said by others or on the questions that we have here for the beginning, or also to the audience if they have a question at the beginning related to these questions. So please, just any comments? Statements or
happy to make a couple of reactions, and hopefully Frank will be able to join in as well. No, thanks for the other presentations and for the comments. I wanted to briefly reflect on what Mia was saying and this barrier that's caused by the new language and terminology that the E9R1 introduces. And this is at risk of sounding defensive. We had to use language to write something down. And these words, treatment policy or intercurrent event, they're meant to communicate a concept and to put something down in a guidance document that people can digest along with the training materials and learn what the Estimands framework is trying to say. Actually, what I really liked from Mia's examples, and whenever I do training or coaching around this with companies, is that you don't have to use those terms when you're talking. When you're talking to a clinical team, you barely ever use those terms until teams are comfortable, and then you start to use them as shorthand. And I encourage you all to try and work in that way. We can have plain language conversations around Estimands, and we should try our best to do that. And it's nice, Laura, that the plain language use is encouraged in the regulatory assessment report. Estimands did not bring problems. Early deaths in neuroscience trials, patients stopping taking treatments, patients taking medicines that they shouldn't have done under a particular protocol. It all always happened. Just gives us a better basis to talk about it in advance and work out what question it really is that we're interested in. Laura, you talked about clinicians aiming for consistency. At least one clinician, if not all of them, but aiming for consistency. I really encourage people to think very hard what we mean by consistency. Again, choosing treatment policy now because we chose it in the past does not mean we'll be consistent. It will be consistent in that regard, but it might be massively different in terms of the consequences for the trial and the estimate that we're proposing. And we talked about the new wave of Alzheimer's treatments, et cetera, and the shrinking of effect that might occur over time as the changing standard of care over time. One part I missed from saying, because it fell off the bottom of the slide, was it would be interesting to do the piece of research work that looked at the hypothetical question instead, and whether that estimate is more stable over time than a treatment policy question when the treatment sequence in the control arm is changing, or in studies that use rescue medication with different rules or different rules for implementation of that rescue medication use, or a population that needs to use rescue with different frequency. I think the hypothetical could well give us a more consistent message about those drugs over time than the treatment policy question could. So just some initial reactions, and then I can't wait to discuss Greg's principle, but it actually fits under one of the questions, so I guess I'll wait for now.
Can I quickly say it's nice that you mentioned Alzheimer's as an example, because we have estimates implemented in the EMA guideline, and actually for the initiation of symptomatic medication, a hypothetical strategy is recommended with a big conditional on reliable estimators being there. And I think that's, again, coming back to the topic where we as statisticians need to provide the solutions so that clinical trials can answer the questions that they are supposed to answer. And obviously the guideline was written before the anti-amyloid antibodies. So I think it's a discussion on how far this will can be extended, the thinking, or whether it's different. But at least for symptomatic medication, I think the problem is acknowledged. And I think, Greg, if I think back to your principle, I think the recommendation from the guideline probably would violate the principle, because it would be aiming at demonstrating kind of the pure effect, because you would like to do a trial that is very long for a disease-modifying treatment, but then you cannot. So you alter the question and say, well, I'm going to do a shorter trial, but then I'm interested in the effect if rescue medication had not been initiated, because that would actually blur or reduce the effect that I'm interested in.
Okay, any questions from the audience?
Yeah, thank you for these interesting presentations. Maybe a thought, a variation on this fourth point on precedent and lack of experience. I wouldn't say it's necessarily that, because I think across the whole decision pipeline, there's a lot of very educated people who are very aware of what the options are. But there's also maybe a risk aversion, and I think that's also justified. When you think maybe you start in a development team and these are informed people, and usually it's quite easy to say, hey, I've got a great idea here. And then it goes to leadership, and maybe that's already a bit hit and miss. Are they really up to date on everything or not? But usually they are. But then they say, well, but can you guarantee this will go past all the regulators? And then you take it not just to one health authority, but actually to a number of agencies, and they may have slightly different positions. And then they might say to you, okay, we actually don't like this. We want you to do that instead. And then you have the positions on 3 or 4 agencies, and you need to try to kind of somehow consolidate that and address that. And even if you think you can do it, that of course adds some delays and some uncertainty in the process. And in the end, if there's various preferred analysis method, it might turn out that the results are not exactly the same. And if there's multiple analysis methods that people feel are relevant, and they see maybe some of them give a good result and some give a bad, you have the risk that a health authority, of course, has the right to say, well, because there's a method that gives a bad result, we think we should not approve this. Whereas if you have a very simple setting, if it's a treatment policy, for example, you might say, hey, this is justifiable. There's not really a lot of discussion here, maybe a bit of sensitivity analysis, and we're done. So I think this risk aspect is quite relevant.
Yeah, comments from the panel on that, or? Okay, then.
Maybe kind of slightly related, since we're talking about the perception that treatment policy is maybe the default strategy. I think if you did a rough count on strategies recommended or used, it would be probably be the most often used. But I would argue it is not and should not be the kind of the default without thinking about your setting. We've published some work based on a review of scientific advice in CNS, looking at the recommended strategies for different intercurrent events, and treatment policy was often recommended. But there have been other strategies as well, and that depends on the specific clinical setting, what is adequate. And also, if you look at the EMA guidelines that do include a discussion of the estimate, you will see that other strategies are mentioned as well and are discussed as well. So I think I would like to a slightly more nuanced discussion of treatment policy, yes or no. I think that's not bringing us anywhere. But within a specific clinical setting, what is a relevant question? And I think as of now, treatment policy still does answer relevant question for certain intercurrent events, as you've shown in your first examples, but maybe not for all.
Hey, I've heard this before about intention to treat analysis and how it's conservative. And that argument I've only ever heard from a statistician. My agency wishes to support the Estimand process, okay? Estimands are easy. They're as easy as you want to make them. They're as difficult as you want to make them. The reason why ITT analysis has been preferred is because the randomization plus ITT leads to a fair comparison. So the purpose of a trial is to compare outcome between two arms of the study, okay? A fair comparison. When you move away from that, you are moving away from fair comparison. You're degrading that fair comparison, okay? So you're now in a catch-22 situation where you hear the regulators saying they want an ITT analysis on the one hand over there, and over there, the regulator wants you to do this Estimand process, okay? Whenever you interact with the regulator, you only have two hurdles to cross. The first hurdle is that you have to clarify what you're doing so that I understand what you're doing, okay? The second hurdle is you have to justify what you're doing in the hope that I will accept what you're doing. So if you've got this conflict between ITT and an Estimand process, whatever that Estimand is, justify what you're doing, put it up for discussion, and if the regulator says, yes, that's fine, well, fine, what's your problem? There is no problem. Just justify what you're doing. And as professional people, as statisticians, you should be able to do that.
Okay. So maybe, please, anyone?
Kind of triggered to immediately respond, but I think actually the estimate framework, part of it is providing a framework which allows us to do that fairly precisely. So I think we're on the same page here. I want to take a slightly different perspective and also maybe trigger one or more panelists to respond to Greg's core principle. One thing that, is, at least in my mind, from the start of the estimate discussion, is realizing that we rarely have only one research question to address before making any decision, and that we will use the same clinical trial in that process. And I do not, and then I would have the reflection of the panel, which doesn't necessarily mean we have a multiplicity problem. So I think being aware that maybe instead of looking for the one primary estimate for this trial is actually do thorough thinking about the research questions in total we would like to answer, and how much of that we can actually have in one trial. Where do we need other evidence to be able to address that research question appropriately? Because for me, that's one part of the estimate discussion as well. I'm kind of also looking for reflections there, and also the connection to multiplicity. And just to give you a provoking thought, we have the estimates for the regulatory approval and market authorization. Our HTA colleagues are not saying goodbye to their PICO assessment. So for those of, I hope most of you are aware of that part. That will not disappear. And I've had discussions there that they actually are against predefining that, defining that at the clinical trial design stage, because at the time that they do their assessment, actually the proper comparator might not be reflected at all in your clinical trial design. So kind of thinking a bit broader than the one single question for the clinical trial. What about using our, let's say, the learnings that we have here for the, let's say, the broader assessment across decision making?
Yeah, happy to give some reactions, Kate, and thanks for the comments. Lots of questions to address. Yes. It would be easy to get caught up in multiplicity discussions when there are lots of questions. Yes, agree.
Yeah, no, no.
Where do I sign for the fact that the world has gone way too far in terms of type 1 error control? Just tell me where to sign. That's a discussion for another day, perhaps. What was the other? Oh, the PICO. So PICO, as I understand it, defines a sort of design space for a decision problem. I have a population, I have an intervention I'm considering, I have a comparator eventually that I need to compare it against, and this is the outcome I'm interested to compare. It sits perfectly happily alongside Estimands discussions from my perspective, which are that next level of granularity. Okay, we have attributes around population, treatment conditions, outcomes or variables, etc. But the Estimands gets into the what is it we're trying to estimate in respect of the intercurrent events that are not part of the PICO thinking or discussion. So to me, they sit perfectly happily alongside each other. You challenge someone to get into Greg's principle. So, okay, very happy to do that if that's okay. Yeah. So, no, Greg, thanks for outlining that. And I think there are many conditions, in particular, those that are seriously debilitating, life-threatening, where it would be hard to disagree with what you'd said, and particularly the idea that a patient might be undertreated in some sense compared to a standard of care. There would be consequences. I'm of the opinion, I think it's sort of generally accepted, that it is good to have a therapeutic armamentarium. It is not a bad thing to license a new drug, even if it's not better than an existing drug. The profile of adverse events might be different or whatsoever. So I think your principle leads us to more active control studies and possibly more non-inferiority studies with all the various challenges that those bring forward. I like Florian's example of the Alzheimer's disease, where we might start treating in preclinical AD or very early AD with a disease-modifying therapy. Actually, patients who don't benefit because they've been treated under current standard of care that only has the symptomatic treatment, at least until the anti-amyloids were approved in some jurisdictions recently, might eventually progress to later stages of the disease and use symptomatic treatments much more extensively. That's going to have a big impact on the assessments of cognition and function, and may render a truly effective disease-modifying therapy to either have a failed study or a much smaller treatment effect than a hypothetical question, as if those rescue medications were not available. I'm not convinced it's a better basis for decision-making. But Greg, the one I really want to challenge is around symptomatic treatments. And at least I would contend that comparing against the placebo to trying to understand the efficacy and safety properties of the experimental drug sort of in absolute terms versus a placebo is a perfectly good basis for a prescriber to make decisions and for a patient to be informed about the possibility or the likely outcomes of receiving this particular intervention. And if it's the one that works for me, I'll take it for longer. And if it's not the one that works for me or I can't tolerate it, I'll move on to the next one, and I want to understand the properties of that particular drug. Understanding the outcomes on treatment sequences as they might relate to sequences in clinical practice for symptomatic conditions, to me, doesn't give us more information or a better basis for regulatory decision or communicating relevant drug effects. But that's exactly where the interesting conversation is, I think.
Okay, yeah, please. Now we want to ask if our virtual panelists, who we can unfortunately not see here, do you have any comments, Greg, or one of the other, Frank or Mia? You want any reactions on that?
I mean, I can make one comment, but I would like to hear, others' perspectives as well. I appreciate the comments, Rob, and others. In the symptomatic disease setting, I understand the perspective that kind of trying to understand the effect of the drug, the pure effect of the drug versus nothing might be, I don't recall your exact language, but good enough or good for facilitating or providing information to inform decision-making by patients and prescribers. But I guess where I struggle a little bit is understanding why it wouldn't be more useful information to try to understand the benefit risk profile of selecting a treatment as compared to the other treatments that a patient or prescriber might actually realistically select in clinical practice. So that's where I struggle. I mean, there are certainly symptomatic diseases where choosing no treatment is a reasonable option. So you consider, perhaps patients with more mild disease. And in those settings, I understand very much the relevance of that comparison. But in settings, I worked a lot in rheumatoid arthritis, where trials can typically conducted in patients with moderate to severe disease, in which, no treatment is not an option in clinical practice. So I think for making treatment decisions, it's always seemed to me that what patients and prescribers really want to know is how is the expected benefits and risks of a candidate therapy as compared to what else they might choose. And so that's where I struggle a bit. And I completely, I completely recognize that this sends us down a road of more active controlled trials. We would have to therefore embrace and tackle the challenges of non-inferiority in more settings than we currently do. But I guess, looking at your 1, 2, 3, 4, the reasons here, my reason would be number one. I think it's the right question. And you have trade-offs to make. And the trade-offs there would be trying to design and conduct and analyze the non-inferiority trial in an appropriate manner to answer the right question. Trying to do our best to get reliable estimation, but in my mind, it seems like it's the right question in many cases. But I definitely hear the alternative perspective there.
Okay, thanks. I think we have here one question.
Yeah, a question and a comment. I'm Diane from Roche. So something that I haven't heard in this panel discussion and in the session was that it's not only the kind of the statistical method or the communication with the clinical scientists that we really need to define a good estimate, but we also need to make sure that we really get cross-functional buy-in from all the function. And especially, I think the operations, the safety, and the regulatory scientists are really crucial, because otherwise we can run into situations where we maybe under-recruit an important subgroup that's maybe an important estimate for our trial, or where we don't collect the reasons for treatment discontinuation, and then we can't distinguish between the different intercurrent events. So that was certainly a learning for me over the past year or so, that we really need to make sure that we really have all the functions at the table.
Okay. No.
Okay, so whatever I say, remember, it's just comment. There is no conflict on this side of the table here, okay? We're all speaking from the same book, as it were. I work in pharmaceutical medicine. There's very little written down about pharmaceutical medicine. It's passed from those who are experienced down to those of us who are less experienced, okay? So it's very difficult to find out anything. So I'll tell you what I was told, and this is the model that I work to, okay? And I will address some of the issues that you've raised, but also some of the issues that others have raised, because you may or may not have noticed. So you used the phrase clinician scientist, okay? European regulators refer to either a scientific question or a research question. Those outside that arena refer to a clinical question, okay? So we'll use that as a starting point, and I'm now going to explain things. And like I say, you can either take it on board or you can dismiss it. I'm not bashing about the head. Statistics is a science, okay? You are men and women of science. You inquire on the data, you learn from the data, and then you go away and establish how those data were generated. You then sit down with your interested parties and you work out, in this case, an estimand. And then you come back with a model that embraces the data and can report on the outcome. A clinical trial is a clinical trial in name only. Okay, it's called clinical because you've got somebody in a white coat who's probably a physician dispensing or prescribing the investigational product. You've got a schedule of events and a pharmacist who's dishing out the investigational product, okay? Clinical in name only. A clinical trial is an exercise in science. Scientific inquiry, okay? A clinical trial follows the scientific method, okay? The question that's been asked is a scientific question. There's a scientific purpose behind the trial. If you call it a scientific question, your clinician, who at present you can't see for dust because you're calling it a clinical question, he's disappeared out that door and he's run a mile, you've removed that threat from him. Not only that, but by calling it a scientific question, you remove this clinical question element, because if you call it a clinical question, you are absolving yourselves of responsibility. You're saying it's not me, it's the clinician who should decide how to compose this question. Okay? Do you see? You are people of science, you've got your own professional abilities, stand up and take your responsibilities. Call it a scientific question, and if you want to, embrace the clinician, call him a clinician scientist. You've removed the threat from both you and the clinician, and you can both take part in a scientific environment where you should feel comfortable and you shouldn't shy away from. I can say more on that if you want me to, but I better shut up while I'm going still good.
Okay. Monica Daigel, Roche. I have a question about how can we use the Estimand concept to help us informing better statistical testing strategies. So thinking about also the various stakeholders, when we define what works does from our regulators, there might be multiple estimands involved that need to, hypotheses need to be proved for multiple estimands or alternative estimands. And then we have other stakeholders and beauty is in the eyes of the beholder. So maybe the definition of value rather than benefit risk ratio is more of interest to them. So how can this concept help us also understanding when it's perfectly defined to use the same data to test alternative null hypotheses according to the type of questions we want to answer?
Maybe we can make a parallel to the very first session where we've seen a trial that was kind of well designed to not answer one stakeholder's question, but several. And instead of having several arms, you can well imagine having several estimates in that trial. And then I think it's up to the sponsor to make sure that they follow the respective requirements from the stakeholders that they want to answer the question for. So regulatory agencies usually require type 1 error control that would hold for the respective estimate of interest. For prescribers, that might not be as important. For HTAs, that might be different as well. So I think these type of questions you can fit very well under the estimates framework. So I'm not seeing a conflict there. But at the same time, it's also not kind of carte blanche to include several estimates in the same trial and, for example, do not account for multiplicity where it would be needed.
I think this relates to Kit's question to some extent, doesn't it? And I hope there's still enough common sense in the world and enough confidence in the sort of professional competence of scientists who are looking at data to be able to make sensible interpretations of data even outside analyses that are under control of type 1 error. Now, if your other questions that are being answered are against the background of a whole pre-specified primary analysis, which is absolutely an important part of clinical trial work, no question about that. which has failed, and a bunch of other endpoints and analyses have failed, and you found one that's positive that happens to be for another audience, I hope everyone's grown up and sensible enough to laugh you out of the room. I'm sure you wouldn't do that personally. If you've got a generally positive trial, you've already shown that the drug has an effect on one variable under control of type 1 error, asking a different question in respect of that variable, another estimand, another analysis for another stakeholder should be perfectly interpretable in general terms. Yes, I think we need common sense as well as rules.
Thank you. I'd like to reflect on image. The image of the hypothetical estimand, or the umbrella term that it refers to, is bad, as it were. The image of the composite estimand is pretty good, as it were, and it seems sort of much more relaxed, and people would seem more comfortable in using it. But in fact, they might be sort of targeting fairly similar clinical questions. I wondered if the panel had any observations about that.
Maybe one point to connect very briefly. You mentioned conservativeness, and maybe we can also use a different term in terms of nested estimates if you want. So if you answer your one question of interest, you kind of also answer a second one and a third one, which are easier to answer maybe. And I think that could be one of the reasons why the composite strategy has such a good image, because I think it allows for kind of nested questions that are kind of conservatively answered by answering that question. Just one hypothesis.
Thank you very much for the interesting session. I'd like to maybe briefly follow up. Sorry, did you want to say something?
Yeah, hang on, Muna. Calm down.
I'll wait, sorry.
Sorry, Laura, did you want to say something?
I raised my hand very quietly. But I think it was the second part of your question about whether they're actually addressing the same question, the composite and hypothetical potentially.
Yeah.
Okay. There's actually an example I was planning on including in my presentation, but didn't end up, was say with the CAR T therapies, for example, in the single arm setting. First, we look at the response rate, and then we look at the duration of response, of course. And one of the intercurrent events there is stem cell transplant. And typically that is currently handled using a hypothetical strategy. But I do question, especially in the single arm context, whether a composite would be more appropriate there to actually think about transplant-free duration of response. And there, I think the clinical questions are quite different. And I think that's really where bringing the clinician in, kind of why would these patients need a stem cell transplant after CAR T therapy? And yeah, what does it mean for a patient to not have that available, I guess? So I guess that's one example where I think the questions are quite different, but perhaps there are other disease areas where it's perhaps leads to a similar question.
Just very quickly, I don't know if you were reading over my shoulder earlier. I've just been reviewing a protocol that describes a hypothetical strategy where it would be used if a particular rescue medication was needed. And the idea was, if that rescue medication had not been available, that patient's outcome would have been very bad, and we should predict something very bad for that patient. And as you say, that's quite close to a composite, isn't it? That the occurrence of the intercurrent event represents some sort of failure, and we should include that in the analysis. So I see exactly where you're coming from. And composites have been attractive, I think, in part because all we have to do is change the variable in some sense, and then we can run our regular ITT analysis, and it's therefore liked. Whereas the hypothetical somehow involves making up data, and even where people can understand that that gets us to a clinical or research question of greater interest, the idea of making up data is a sort of antithesis, and nobody, it's disliked for that reason. It was also a bad choice of name, but honestly, we spent hours on that in the working group and couldn't come up with anything better. Sorry, Muna.
What were some of the alternatives?
Frank will have to help me, but there were certainly some members of the working group pushing for words with a more positive connotation than hypothetical.
That may have helped. Thank you for the nice session. I wanted to briefly follow up on the conversation around treatment policy and the clinical relevance, let's say, so between Rob, Frank, as well as Greg. And Greg, who mentioned that he would vote for, let's say, the I in this question, right? That it actually genuinely reflects a regulatory clinical question of interest. And that indeed, in the long term, this may also mean more active control trials, maybe more non-inferiority trials. And I guess I wanted to follow up on this, sort of asking the question, at what point in time would it be relevant, right? Because usually when we design a trial and we have a competitor in mind or a control arm in mind, this will be a very time-sensitive sort of decision, right? So it will depend what other treatments are on the market, what is approved in that particular country, let's say. So if I run a trial today and I start a trial today, 2 weeks later, there may be a new drug being approved. So suddenly my competitor arm or my control arm may no longer be relevant. And that clinical question that I'm assessing through the treatment policy strategy may no longer be relevant for no country and for no patient ultimately. So I guess I'm trying to get to the point, is a treatment policy strategy very generalizable and transportable and time insensitive, let's say, or will it always depend very heavily on the context that we are currently looking at? And then when we talk about non-inferiority trials, there was a very interesting session at the PSI conference that took place earlier this year. And there was a discussion around when we do non-inferiority trials, is it essentially that we want to do an indirect comparison to a placebo trial ultimately? And so then we are again in this placebo-controlled setting, right? So yeah, just a couple of questions about that. And then my last comment is, we say treatment policy, but what policy are we actually laying out in our protocols? For me, the way to interpret treatment policy, the only way I can really interpret it is the effect of initiating a certain treatment strategy, is initiation, is the effect of randomization, because I have seen very few protocols which actually say, start this one, if this doesn't work, do this, if this also doesn't work, then go and do this. So we don't really lay out a policy, it's almost saying, what is the effect of initiating this? And if that is still clinically relevant, I'm not so sure. So a lot of comments, but.
Okay, so again, I'll try to address your question, okay? And bear in mind that this is how I was told, okay? So I'm not trying to impose myself upon you, and you can either take it or leave it. Okay, a clinical trial is an exercise in science, scientific undertaking, okay? The focus of the trial is the product. The focus of the trial is not the patient. Now, of course, if you're in a company, you'll take great lengths to protect that patient safety-wise, and the regulator will go to extremes to ensure that you ensure that safety. But the focus of the trial is the product. A product has efficacy, okay? And that efficacy is constant. You're not treating a patient, you are exposing that person to the product. There's a difference, and this is why I mean there's a difference between a scientific question and a clinical question. You're not treating a patient in a clinical trial. You're exposing them to product to estimate efficacy. I don't understand the phrases intention to treat, treatment policy, or treatment effect. They all contain the word treatment, but I look at these phrases and I don't understand them. I know where these phrases arose, how they arose. I've asked statisticians how they arose, and none of them was able to give me the answer. Two said it was in an ICH document from the 1990s, but none of them gave me the answer. I know how these phrases arose, and you'd be surprised if you knew too. Instead of treatment effect, I would much rather that you use the phrase a measure in my language or estimate of efficacy given the estimand, or given the scenario of the estimand. And then you can come forward with how many different measures or estimates of efficacy given the estimand that you want. It's up to you.
Any reaction on that from the panel?
Just a a brief reaction to that, and I'm sure Andreas and Vivian, you want to go to the online panelists as well. And it's easier to react to John's comment because I agree with everything Muna says and the questions are too difficult. So I'll react to John's instead. And this sort of music to my ears, there's violent agreement here, John, because the whole point of the ICHE 9R1 is that the phrase treatment effect is completely ambiguous. I think I can help with where the ITT principle comes from originally beyond 2 lines in the guideline, but the word treatment effect is completely ambiguous and needed a definition. Otherwise, we don't understand our target of estimation and we don't know what it is we're trying to achieve with our clinical trials. I'm sorry to pick on words, but I thought it really interesting that you said the efficacy of the product, not the impact of introducing a product into a particular treatment sequence, but I want to understand the efficacy of the product. And of course, regulators license drugs, not treatment sequences. And that conversation is fundamental to all of this. Are we trying to understand the efficacy of a product or how introducing a product into a treatment sequence has changed the outcome in that treatment sequences? And the answer to that question is really important in terms of what we write down for our estimands. And that's just another way of what Frank and I were trying to highlight, I think, about the bigger questions that are opened up by these discussions.
Greg raised his hand, so please, Greg.
Yeah, I thought that's a great question. And I mean, our mission at FDA is to protect and promote public health of the United States. And I guess my perspective is I don't know how we reliably achieve that mission without trying to understand how the adoption of a new treatment will impact public health. And that includes, as I think has been pointed out, not only the pure effects of the drug, but how it might impact the probability that patients will go on and take additional medications, their eligibility for those, how they respond to those additional medications. And so the introduction of a new therapy to clinical practice can have net effects on public health through many different directions, and trying to understand those net effects to me is consistent with our mission. So that's my perspective on that. And just one follow-up, I think it was Muna who asked some really good questions. I won't comment on all of those, but I do agree that in circumstances where there's kind of rapidly changing standard of care, that can present challenges. So I don't, I'm not discounting those challenges at all. And I think that those require, very complicated discussions in the individual settings. I do think there are many therapeutic areas where those challenges are not there. Like there is very stable available therapy known to be safe and effective that are not given to patients on the control arm of designs. So that, I think very important questions and points that were made that I don't have answers for, but just wanted to follow up on that.
Yeah, okay, so I heard that Frank also raised his hand, so please, as we haven't heard you, so for the wine tasting, I think you have the final word, so please, Frank.
Okay, so I'm just between the wine tasting, so I should keep my remarks very short. Greg, you don't know, and me at the FDA, but there's always a tradition of having wine tasting, and apparently it starts immediately. So, yeah, so I think this is really a great discussion, and I really enjoyed all the discussions and the questions being raised. And I agree that I also don't have any answers to that. Actually, I just wanted to add further questions, in particular, but not only related to or triggered by Greg's latest comments. So I think we are at a stage where we should discuss about principles that guide us about the choice of estimands. And Greg, you started off with one possible principle, but your latest set of comments made me wonder why we are actually running the clinical trials that we are running, and what's the purpose of these clinical trials, and maybe John, I think you had also some comments in that regard. But are we developing drugs or treatments? And with treatment, I mean sequences of interventions, and with drugs, I mean just the drug effect. and I think, Rob, you was alluding to an earlier conversation throughout the day that I must have missed, but you mentioned that maybe we are making distinctions between an approval of a drug versus the information provided in the label for the prescribers. Are these two different estimates? So I think there's a series of relevant questions, high-level questions that could all help us in providing principles by understanding whether, for example, we are developing drugs or treatments, whether clinical trials or to which extent clinical trials should reflect clinical trial practice. If you have answers to those questions, then I think we are one step further in coming up with reasonable estimates rather than circulating between hypotheticals, composite, and treatment policy, and always saying we don't like the one, so we move on to the next. At least it's some of my experience, and without integrating clinical perspectives into that. So I just wanted to add further questions to this round of questions. But I see Rob is standing up, so hopefully he will have further comments to that, and maybe he has the final words.
It was only to get a drink, but and not wine. But I think it's a brilliant comment, and maybe it's the one to end on. But the brilliant comment, Frank, that if we get to grips with some of these more fundamental and principal questions, the whole conversation about strategies will be easier. I think that's a